Hey, Ed, what are you doing over there, man? Haven't seen you in so long. That's since COVID kicked us out of the building.
Hey, Bruce, good to see you. Man, where did the beard go?
Things change.
Oh, jeez. How are you doing?
Doing really good. How about you and your family? You still have toilet paper?
Oh, yeah. Yeah, we're doing good with the toilet paper. No problem there.
Guys, guys, this is live. You're on.
Oh, whoa, sorry. I didn't realize. Hmm.
Yes, sorry. Our apologies. Good afternoon. We'd like to thank Brian Lick and all the conference organizers for the invitation to present on ECMO and ECMO education. Bruce, ECMO is near and dear to our hearts. Both clinically and philosophically, we believe that ECMO is an important part of the perfusion scope of practice. In short, we like ECMO.
Yes, we do, Ed. Maybe this is a good time for us to get our disclosures out of the way. We'd like to disclose that we are both consultants for a group called ExtraCorp. They do ECMO consulting and ECMO education all over the country. But today we're actually here as university professors from the State University of New York and ECMO hospital consultants for our local team here in Syracuse.
So let's talk about developing ECMO competence during initial training.
Is that even a thing, Ed? ECMO competence during school? When I went to school, I'm not sure I saw any ECMOs at all.
That's the thing, Bruce. Look at the differences in our perfusion training while we were in perfusion school. You had no ECMO. I had a pretty good ECMO experience as a student. And I'll bet if we surveyed everybody that's watching us, all the perfusionists out there, that apart from the bypass experiences they had in school, they would have vastly different experiences in the other subspecialties that we have in our scope of practice, like pediatric perfusion, blood conservation, and ECMO. So how confident should a new graduate be in some of these other subspecialties in our field?
Ed, Bruce, I really hate to hurry you, but you need to move this thing along.
Hey, back off, Bill.
So, Bill, I think that what Ed's trying to get at is this thing that we did when we transitioned our program to a master's degree. That thing where we identified a bunch of specialties, and these are specialties that we know are very important to the field, but are often undervalued in the educational process. And we carved out an area in our curriculum so that students could spend special time on them, becoming really good experts on these particular subjects. And there's lots of time in the curriculum for them. They spend like 37 weeks training in these areas of specialty.
Yes, exactly. We call these our capstone experiences. We all know that every perfusion student that graduates has entry-level adult cardiopulmonary bypass skills. But does that make them skilled in the other areas? Does that make them skilled in pediatric perfusion, or ECMO, or mechanical circulatory assist, or blood management? Um,
Oh, hey guys! Oh, I'm so sorry. I didn't mean to interrupt.
wow, is that Ashley Hodge, chairperson of the AMSAC Pediatric Committee? Hi, Ashley, what's up?
We just recently had a student who went through the pediatric capstone, and she was incredible. She was much more prepared than a lot of the students that we get. She had an increased level of knowledge, of didactic knowledge, and truly had a passion, you could tell, for this subspecialty and specifically in pediatrics. So it was really, really nice to have her with that increased drive and some additional time that she is spending truly researching this subspecialty. So fantastic job to SUNY, and we're excited to be part of this journey with you guys.
Thanks, Ashley. Feel free to hang around for the rest of the talk.
Oh, sure. We would love to stay. Hey guys, come join the party.
Another area of specialization is our topic today, and that's the ECMO Capstone experience.
You hear something?
Hey, hang on, let me take this phone call.
Hi, this is Jeff. Great start to your presentation.
Wow, it's the legendary Jeff Riley. What's he doing here?
But I have to share something with you. When I was at the Minnesota State Perfusion Society meeting, I was taken back by the number of participants who told me that perfusion graduates, perfusion education student graduates today, can't do ECMO independently, and their knowledge of ECMO is inadequate. What do you think of that?
Well, thanks, Jeff. I've heard that too, and that's why we started these Capstone experiences, to help close the gap on this difference between what the graduates know when they leave school and what the workforce wants them to be able to do. So Ed, how about we do this with the time that's left here? Why don't we tell them about this ECMO Capstone up here? And let's present it as if it were this quasi-scientific presentation according to the IMRAD method.
IMRAD, so you mean introduction, methods, results, the discussion, the whole shebang?
Yeah, that's the thing. You
Okay.
ready?
Yeah, let's do it. So Bruce, as background to this subject, if anyone wanted to develop a curriculum to teach a clinical skill about anything, given what we know about how people learn and the technology that is available to educators today, what should that curriculum look like?
Well, for this section of the talk, I think if we're going to do it right, we should get some animated cartoon experts endowed with incredible artificial intelligence. They're always helpful to have. So these super smart cartoon educators would suggest to us that before we begin to design a curriculum, we need to define what we mean by the word competence. We need to understand a few things about learning theory, and we need to identify exactly what fundamental skills we intend our students to be able to command at the end of this educational process.
Yeah, that makes sense. I remember when we sat down to build this, we discussed the concept of competence at length. There's an impressive body of literature on that subject, but my favorite was the work by Noel Birch in the 1970s. He said that someone learns a new skill as they move through 4 distinct stages. Stage 1, they start out unconsciously incompetent. These people are novices and they don't know what they don't know. If you're a clinical instructor, this is the scariest stage when you are responsible for the actions of a novice. Stage 2 is consciously incompetent. This is the scariest stage for the learner because they have become aware of what they don't know and they know they can't do it well. With continued training and practice, the learner progresses to stage 3, where they become consciously competent. In this stage, if they really think hard and they don't get distracted, with tremendous effort, they can get the job done. Eventually, they will become unconsciously competent, stage 4. And in this stage, they become proficient. They can do the skill almost without even thinking about it. Like how you can drive a car while adjusting the radio, having a conversation with your kids through the mirror to the back seat, while also not hitting the pedestrians and navigating the curves in the road and not blowing through that stop sign. After practicing that for about 10,000 hours, the unconsciously competent practitioner becomes experts, where their performance is marked by excellence and precision without even thinking about the steps that are necessary for the performance. They think, drive the car, and it seems like the car does the rest, as if the car has become an extension of their body with its own neural connection to the brain.
Man, I do love the work of Dr. Birch. I remember you and I asking ourselves as we were doing this, if I were a patient in the operating room, what would be the lowest level of competence I would expect for anybody that was part of my care team? And what did you settle on?
Well, for me, the answer was proficient, which is part of stage 3 of Dr. Birch's circle of competence. The stage where they can do it, but they have to think pretty hard about what they are doing. It's not intuitive to them yet.
Right, yeah, I know that. And remember, we compared that expectation for entry-level competence to the typical perfusion training programs like we have here in these graphs. And what you see here in Perfusion School 1 and Perfusion School 2 is that there's 2 methods of presenting the curriculum to people. And here in this method, the classroom precedes the operating room. Half of the time is spent with patients, half in the classroom. And over on this scale here, you can see the 4 stages of competence that people are going to go through according to Dr. Birch. And what we have in this method is that we make the students kind of smart through the classroom, but by the time they get to the operating room, they still have no skill. So the incompetent student is part of the patient's care. They're not going to become competent until they've done a lot of operating room work. So there's an area of risk identified by the yellow part here. And the other method of perfusion school training, we see that we do overlap the classroom and the operating room. So you think, well, you're getting twice as much operating room experience, so that must be good, right? However, what you see is that now the patient is exposed to a student who is neither smart nor skilled on day one of perfusion school. So we definitely have preserved patient risk.
Right, Bruce. That's when we decide to pull the incompetence out of the patient experience and address it in the university setting separate from the patient. By introducing an immersive simulation curriculum to the program before the student has patient contact, we can teach and measure clinical skills prior to patient contact and make sure that a student is at least minimally competent before they ever touch a patient.
Absolutely. And with that kind of a training program, what we need to understand then is a few things about learning theory. So let's get this other cartoon expert. And she's going to tell us that there's 3 elements of learning theory we need to understand. And those are autonomy and mistakes, repetition, and self-reflection and mental processing. And let's describe how we take those 3 elements and put them into our curriculum. When a student trains in a clinical environment, they're never allowed to make a mistake.
Heck no, you cannot make a mistake when you're taking care of patients, and a perfusion student's clinical preceptor will not let them make a big mistake.
Right, so they do what they're told, when they're told to do it. They never see a mistake, they never make a mistake, they never learn how to dig themselves out of the holes that mistakes present. Take a look at this little student here. She'd like to test her understanding of Poiseuille's law and throw a clamp on right after that pump. What do you think about that?
That'd be crazy. She shouldn't do that.
I know, but subsequently she's never going to learn her lesson about this because she's not going to be able to do that in the operating room. But in the sim lab, we encourage mistakes. We celebrate them as great learning opportunities, and we set students up to make mistakes, and we let them dig their way back out of the hole, and then we can debrief them afterwards to make sure that the learning has happened. You know, Ed, it shouldn't be front page news when a student makes a mistake. Making mistakes is part of the learning experience. In the sim lab, we can incorporate that right in and gain its full value. The next primary tenet is repetition, where we say, let's train them like athletes.
We learned this one by reflecting on what athletes do and what sports teams do. It's always bothered me that if our job was to put a basketball through a hoop, we would practice for hours and hours and hours in the gym, shooting from every angle, at every speed, so that we might have a chance to do it just once in a real game. Athletes know the power of repetitive practice, but in medicine, we take an untested rookie, put them straight into the Super Bowl, and we practice during the big game.
I know, isn't that crazy? Never made sense to me.
In our sim lab, we can drill and practice and drill until we know the student understands what they are doing on a specific clinical skill and that they can do it correctly. And we can actually measure their performance and make sure they stay on the bench until they have proven that they can do it.
And you know what else we can do? We can incorporate video into this and again continue training them just like athletes. Through the power of video, we can make sure that the students learn at a time when their brain is ready to receive it. In this figure here, you can see this looks a lot like Jeff Riley, doesn't it? This could be Jeff or you or I in the red figure here. And we're working in the sim lab with a small group of 3 individuals. We got one student here in blue, and that student's in the hot seat. What have you noticed when you're working with these small groups of individuals?
Well, I'm always impressed that when 2 students are in the back, they seem so smart, and the one student operating the pump is frazzled, and they can't even spell their name.
I've observed that too. It's amazing, and it's called cognitive load. The cognitive load is so high when you're trying to operate our medical equipment, and you're not really experienced with that, that it devotes all of your brain. All of your higher order brain cells are not available for learning at that time because they're just trying to dedicate themselves to doing. So here, this student is having an experience, and they're really not learning from it like they're supposed to be. But these folks are having a great experience, and they're learning from it. But fortunately, through video, we can video this entire experience. We can speak into the video, and we can annotate on the screen, and we can beam that up into the cloud. Meanwhile, other students down the hall or across the country can be watching that live and remotely, and they can be learning from the experience that's happening in that room. And also, this student that had the experience, they can leave the room, they can get their wits about themselves again, they can get a nice cup of tea, and they can sit down and they can watch that video and finally learn from it because their hands aren't busy and their brain is open and available for learning. By using the power of video, we can distribute this time that we spend in the sim lab to lots and lots of students and make sure that the student who had the experience actually connects the dots. Something happens to them in their physical world, they put it into their brain, and then subsequently they go and process it in their head, and they bring it back out through their hand and write it down on a screen, and that is part of the process, the deep mental processing that creates a deep learning.
So to recap, we set our goal as building minimal competence before patient contact, and we are going to use an immersive simulation curriculum that includes autonomy, mistakes, repetition, and self-reflection to develop these skills. So the last thing we need to know is what skills are we going to develop? I remember when we wrestled with that question several years ago when we determined that cardiopulmonary bypass was not a single skill. We did a national survey and identified that through consensus of many expert perfusionists that there are 20 skills associated with operating a heart-lung machine for CPV. Individual skills like chart review, assembly, priming, checklist, weaning, initiation, myocardial protection, and then the non-technical skills as well, like communication. And since the subject of this talk is on ECMO, then we need to ask the question, is ECMO one skill, or does it take many skills to operate an ECMO system? And if it is many skills, what exactly are the fundamental skills of ECMO that we will build through this curriculum?
You know, that's a great question, Ed. And while we've not researched that one yet specifically, but we may in the future, we do have some really excellent references from which we can glean these skills. For instance, the AMSECT has a standards and guidelines document for mechanical circulatory support. And in this document, they go ahead and make a couple definitions for us. And if you look at the definition of mechanical circulatory support, it is implantable, paracorporeal, or percutaneous, univentricular, or biventricular devices used as acute or chronic support for assisting or replacing failing heart. That sounds like VA ECMO to me. How about you?
I agree with that.
If you dig deeper into their document, they've got 9 standards. Of particular interest today for us is standard number 5, where they cover the responsibilities of a perfusionist in the support of mechanical circulatory support. And they've got things like initiation and setup of support, support of instruction and troubleshooting as appropriate, transport of these patients on these devices. We also talk about perfusionists having responsibility for assessment and of proper and optimal functioning, and perfusionists should have the role of training and education for the entire team. In addition to that, we also have this new initiative from AMSECT and the International Board of Blood Management. And I've invited Jeff Riley to jump back in here and give us a little overview of what they did with this project.
Hey, thank you for asking me to talk about AMSECT and the International Board of Blood Management's new certification exam for adult ECMO specialists. Just like your slide says, at our website we completed a job analysis and have a wonderful job description with over 96 knowledge, skills, and ability statements posted. If you're writing a job description, it's a perfect place to go and see what we produced. The exam has been taken by over 115 persons, 76 of which were volunteers, adult ECMO specialists who helped us validate the test questions, along with the 17 subject matter experts from across the United States who helped write the exam. The exam was offered online 4 times a year, and we'd love for you to have your respiratory therapists and your registered nurses and other non-perfusionist folks who are serving as ECMO specialists, adult ECMO specialists, take the exam. Perfusionists are welcome to take it also. Thank you very much.
And last but not least, many institutions have their own list of competencies. Here are the examples of the competencies that we have at our institution. One for our cardio help circuit. This is the checkoff sheet we use for our nurses and respiratory therapists that operate the ECMO system. We've got one of those for a Thoratech and CenterMag console as well. We have one for the Rotaflow for the other hospital that we work at. So, you know, in the area of ECMO, the skills that are necessary to operate the equipment are probably even better defined than they were for us in cardiopulmonary bypass. So I think we do have a pretty good idea what skills we're supposed to teach. Yeah, so as a method statement, look at what we're going to do here. We're going to take all the students and have them learn a certain amount of information that is consistent for every single student. But then we're going to have our treatment or our Capstone group, and our control group are everybody that doesn't choose Capstone. And the Capstone people are going to do something different here and here. So that's the overall 10,000-foot view of the curriculum. Drilling in a little deeper, what we can see is that there is a 5-semester curriculum, and in the first 2.5 semesters we have clinical, simulation, and classroom experiences that the students go through. And here, admittedly, a lot of this is focused on cardiopulmonary bypass, but down in the second semester over here, we are going to focus on crisis management and ECMO. So our students are going to have a lot of dedicated ECMO simulation, and they're going to have dedicated ECMO classroom work. So in semester 1, we do basic skills of bypass, 2, case management of bypass, but ECMO is in that third step. And these skills that they learn back here, how to use pumps, how to use tubing, how to use connectors, pressure, flow, resistances, all that kind of stuff, is certainly relevant to the kinds of work that they're doing with ECMO. So with focus on the ECMO part, we've got 2 credits of classroom ECMO lectures that every student gets. We've got 580 hours of bypass simulation, which gives somebody a certain skill set that's helpful to ECMO people. And we have 70 hours of ECMO simulation focused specifically on the skills of ECMO and working with ECMO circuits. They used a variety of circuits, and in this stage here in the operating room, they get to use some of these primary learning theory elements of autonomy. They get to make mistakes, and they have lots and lots of repetition.
So far in our methods, all the students are in the same group, but now, at this point, we are going to separate them into 2 groups. One group of students selected ECMO as their capstone, and we'll compare them to all the students that did not select ECMO as the capstone, and they'll be the control group for us. The students in the control group will get the typical ECMO experience of any perfusion student. That is to say, their experience will not be standardized. They will participate in ECMO only as much as their clinical instructors tell them to, and it's an organic process that's subject to random opportunity and personal values. On the other hand, the ECMO capstone students are going to do 2 things that are above and beyond the typical process. First, they will go on a 7-week ECMO-only clinical experience at a very busy ECMO service. And while they are there, they will intern under the perfusion team that is very proactive with all aspects of a multidisciplinary ECMO team. They will dedicate over 300 hours of training to to practice clinical ECMO skills and participating in ECMO team administration and education.
Boo! That's insane. Crazy. 7 weeks to learn 3 things? To turn the flow on? FiO2 and sweep? Really? Seriously? No way. No way. Crazy.
Yes, we get that reaction occasionally. People will ask us, how in the world will you take somebody out of the operating room and put them in an intensive care unit to do ECMO? So that's what we're finding out. We'd like your input on it.
In this third stage of our methods, the other thing that ECMO students do differently is that they have to practice these methods of learning theory of self-reflection and mental processing. They do that by producing a Capstone portfolio. This is a fairly lengthy written document where they have to take the experiences that they've had physically in the hospital with patients and compare them to the scientific literature. They are given an outline that they have to follow as they read and experience and then write. I queue them up with about 25 different references and tell them they're going to have to do 3 or 4 more times of references before they're done. And subsequently, by the end of this, they've written 60 to 100 pages about the fundamental skills of ECMO, and they've read 75 to 100 research articles on that subject. And this helps reinforce the deep learning. They can't just see it and forget it, because later on that night, they're going to have to go write about it. So that's how we did this training, and we've run it one time now. We're learning as we go, but well, why don't I turn this over to Ed? As the clinical coordinator, he collects all the data about what the students do. So Ed, how are these students different as a result of this curriculum?
Well, let's look at it. This is for the class of 2020, the class of students that are graduating right now. We had 4 students do an ECMO Capstone experience. They all did a 7-week ECMO-only rotation. They averaged over 300 hours of ECMO experiences. They did things more than just initiate and terminate sit shifts in round. They also attended the weekly ECMO conferences and were involved in the life of the ECMO program in non-clinical ways as well. So if we compare our ECMO Capstone students with the rest of the class, you can see that our ECMO, as far as total ECMO events collected for our Capstone students, 60 versus the rest of the class, 4. Initiations, they averaged 12 initiations each. The rest of the class averaged 0.7 initiations. Rounding, they rounded almost 34 times. The rest of the class did a few, but not much. It wasn't dedicated. They did over 33.5 ECMO shifts. They had numerous transports. They were involved in numerous terminations. So we see a significantly more robust ECMO experience in our ECMO capstones, as we'd expect. And if you look at the distribution of the types of ECMO, our ECMO capstones saw 60 VA ECMOs, 12 VV ECMOs. The rest of the class, less than 5 of those. They spent time in the ICU, a great deal of time in the ICU compared to the rest of the class, and that's important because the environment in which ECMO is done is much different than the operating room. They did do a lot in the operating room as well, 19 in the OR versus just 2 or 3 for the random opportunity rest of the class group. And they also had family interactions, which were numerous at the bedside up in the ICU, whereas the rest of the class had very few. And so we thought that that was an important aspect as well, that this is a different environment that we work in with ECMO, and that these nuances need to be better understood.
Well, that's pretty interesting, Ed. But I'll bet you that it really compromised the students' experience in the operating room, didn't it? Taking them out of the operating room for 7 weeks. That heckler was right, or no?
Well, actually, no. When we look at the total number of conventional cardiopulmonary bypass cases, the ECMO Capstone students averaged 91, and the rest of the class averaged 96. Now, remember, this year was affected by the pandemic, so all the students were removed early from all their clinical rotations, but they all left at the same time. So we did not really see a significant change in the number of conventional cardiopulmonary bypass.
I'm sure somebody's
cases
curious. How many
completed.
cases do our students usually get? 91 and 96 seems a little low. If it weren't for COVID, what's the average number of cases that a SUNY student gets?
Historically, a student will see at least 120 cases, oftentimes more. It really does depend on what clinical sites that they go to.
Well, that's really interesting, Ed. It sounds like this curriculum really does prepare students differently. What would you say were some of the biggest challenges that we had when we were developing this curriculum?
The biggest challenge was our clinical sites. This is a different paradigm. We weren't looking for clinical sites to do a conventional rotation with an emphasis on ECMO. We are looking for a true ECMO-only rotation. And so communicating our goals with our clinical site and having their buy-in was really important. In fact, let's hear from our two clinical sites that we use for ECMO capstones.
Hi, I'm Karen Smith from the University of Rochester Medical Center in Rochester, New York. We accept students from SUNY Upstate Medical University for clinical rotations, but in 2019, we're able to start having students come here for an ECMO capstone rotation as well. These students who traditionally, if they were on their clinical rotation, would only really see ECMO initiations and possibly a wean and decannulation in the operating room, where now they're able to see a lot more of what happens behind the scenes, more of minute-to-minute, day-to-day care of these patients in the ICU. They are able to transport a lot of the patients to CT, cath lab, and see what goes on in those areas as well with ECMO patients. They're available and around for troubleshooting the circuits more, as well as able to attend meetings and some listings and see what happens to the patients as far as heart failure management. And they really get to see how perfusionists work outside of the OR with nurses and mid-levels and intensivists. So I feel like these students have benefited from being here on clinical rotation and spending time with our ECMO patients in the ICU.
Well, thanks very much, Ed. That was fantastic. It was great talking with you about this program. I think if we probably ought to sum it up here, or Bill's going to just pull the plug on us. You know, in summary, we believe that an immersive simulation curriculum can teach preclinical skills prior to patient contact. We've proven that pretty handily with regard to cardiopulmonary bypass, and we're confident that we can do that with ECMO as well. And we think that this combination of intensive immersive simulation, preceptorship with clinical experts, and a formalized self-reflection process, that is the portfolio, that will help prepare entry-level graduates for the specialty of ECMO. What we're hoping now is that people at the conference will give us some feedback. This is a new and novel approach to teaching ECMO for our perfusion students, and we'd really like to hear from the market, the employers out there, if this kind of a graduate meets your employment needs. So thank you very much. It's been a pleasure speaking to the Sanibel Conference.